All right, welcome everyone for our um, fortnightly, roughly every 2 weeks. We're going to be holding these Q&A sessions. It's a brand new thing that we're doing, um, but there are some of you who are interested in our June live stream event, but you know dates might be conflicting, or the time zone where you're joining in may not be suitable. So we have this option where if you can't make the exact live stream, or you can only make half of it or whatever, you still have access to the recordings from last year's event, and you'll get the recordings from this year's event about a week after the June 6th and 7th, the 2-day intro event. But we have these supportive twice a month Q&A sessions with Dr. Wong. They're going to be at this time, which is a little bit late for those of you like me in the East Coast in New York, 10 p.m. Eastern or 7 p.m. Pacific on Wednesdays. Uh, yeah, and Thursdays if you're in Australia or if you're in Malaysia or Asia, it'll be Thursday morning or noon time. So welcome, Christine. Oh, Christine joined us last year at last year's event. Welcome, Dr. Fong, Dr. Nguyen, and Dr. Jetley. So we're just going to open up to questions. If you want to, Dr. Motion, welcome, welcome. If you want to ask questions on your microphone, you don't have to turn on your video. Just raise your hand, and we'll open that opportunity. So you can just talk through your microphone, or if you would like to type in a question, there is a Q&A panel. There's also, hello, yes, hello, Shema. Welcome, welcome. Tell us where you're joining in from. Right, so this is just, every 2 weeks we're going to have this Q&A session. Some of you have USA, terrific. Are you a dentist or allied health professional? What type of dentist? Yeah, tell us a bit about yourselves. It's a small group, only about a dozen people registered tonight, and we'll be lucky to have half of them join. We had a really big webinar about a week ago with Dr. Uh, Kevin Boyd, with over 500 people registered and about 300 people turned up. So we had a really big webinar last Monday. We're here because we've extended our webinar special until tonight, actually, in a couple of hours. So the agenda tonight is to answer any questions you have about early interceptive postural orthodontics with the founder himself, Dr. Wong, my brother. He's based out of Australia, but he's been training dentists around the world for the last 5 or 10 years, via Zoom and in person. So we're going to open up to questions, 30 minutes or so, and then Simon has to head off in about 35 minutes. Grab some lunch before he gets back to work. It's lunchtime now, but yeah. So if you have any questions, we'll open it up to Q&A now. If you'd like to speak, just raise your hands, and I'll open up the ability for you to use your microphone. If you just want to type in your questions, you can do so as well. All right. So anyone who'd like to get started, any questions or comments? Actually, Simon, we got some questions online because we have this. For those of you who aren't aware, I'll just share my screen really quickly as you're typing in your questions or thinking about your questions that you might have. Yeah, so you have this website, straightteethnaturally.com/ask. I'll just put the link here so you can save it. But this is where you can register for our free Q&A sessions roughly every 2 weeks. Unless something urgent, Simon can't make a particular Wednesday. He generally will be on every 2 weeks. Wednesday, either 10 p.m. Eastern or 9 p.m. Central, 8 p.m. Mountain, 7 p.m. Pacific, which is 12 p.m. Melbourne time, his time on a Thursday. And as you can see, we've got this new program. It's an AI-powered chatbot. It sounds cool, but it's just ChatGPT incorporated with about 2,000 pages of transcripts of Simon's actual paid events that we've done over the last 5 or 6 years. So it's actually pretty accurate, 80% of the time. And as you can see here, when they're not super accurate, Simon will make adjustments. And, this is when you can actually get some real feedback from the real Dr. Wong, not his AI version. But we had questions like this, Doctor. Does Dr. Wong ever use a palatal I don't even know how to pronounce that. I'm not a dentist. To assist stubborn maxillary expansion in older patients. Dr. Wong does not typically use palatal corticotomy to assist with stubborn maxillary expansion in older patients, as his practice primarily focuses on younger patients. For adults or older patients who struggle with maxillary expansion, emphasize the importance of addressing skeletal problems surgically rather than relying solely on dental expansion techniques. So, we've gotten over 100 questions that this AI system kind of helps a little bit. But as we say, this is beta. Don't treat it as more entertainment rather than advice. In fact, don't treat it as advice. It's just an AI chat bot that gives half decent and not always correct answers. Sometimes it uses its knowledge base from around the world, which is not necessarily what Simon would answer. So I'm just kind of buying time to see if anyone has asked any questions. Let's see here. No questions yet. Christine, welcome back. How was any comments? I mean, you attended our in-person event in September, which was in New York, in New Jersey, beg your pardon, at the Hilton. Yeah, feel free to, share some of your, I'm sure you got some questions for Simon after going through the program. Let's see if anyone else has any questions. Okay, Simon, how about you just answer some of these questions that came in recently while we're waiting for, I'll share my screen. How does Dr. Wong describe the perfect lower arch while expanding in the primary dentition?
So we need to have a form that will allow sufficient width for the front permanent incisors to fit.
Sorry, I lost you there, Simon. Can you hear us? He dropped off, I think.
Like
Oh,
a
sorry,
balance.
we lost you for a whole minute, 30 seconds. Sorry, if we can get you to start your answer again. How would you describe the perfect lower arch?
Well, we would like sufficient width for all the permanent front teeth to fit nicely. We would like sufficient depth for all the posterior molars to fit in nicely. We'd like a curve of Spey and Wilson to be reasonably flat. And we would like nice balance with the upper arch. So that's the general hope of every orthodontic intervention. So that's basically the arch. Now, what we will see when we're in primary dentition, of course, is only the primary teeth. So depending on at what point in the age range of primary dentition, we're looking at anywhere between 2, where the full 20 teeth have come through, up until about 6, when the permanent molars start to erupt. In the width, initially we don't expect much in the way of spacing, but between 2 and that 5-year timeline, we should start to develop enough space for the adult incisors to fit. So primary teeth should have gaps between all all the incisors so that the permanent teeth, which are roughly 50% larger than the primary teeth, will come through nicely in that 6, 7, 8 age group. So if we're not seeing space enough to fit a coin between each primary teeth, then once we hit about 4 to 5 years of age, we know that the adult teeth won't fit, and that 12-month timeline is unlikely to have enough organic growth for it to have the space needed for the adult teeth. Effectively, we can't expand the mandible after 2 years of age, 18 months of age, but we can develop a better arch form in the dental alveolar and relationships. So dental alveolar extension in primary dentition takes up 3/4 of what we would call the mandible. Adults, the dental alveolar will take up less than 1/3. So what we can do in the primary dentition is very different, because we can develop enormous amounts of dental alveolar development, and because the bulk of the mandible in primary dentition is made up of teeth and unerupted teeth, the tooth buds, we can actually get significant translation of the primary molars, and it will often carry the buds of the permanent teeth along with them.
Good. There's a follow-on question. Does he measure intermolar width at the lingual gingival margin on the lower or upper first molars?
Intermolar width is a measurement that we take typically from the upper 6-year-old molars, and it's from the gingival margin to gingival margin at the palatal aspect.
Okay. Dr. Wong, let's see if there's any other questions. Nope, no questions have come in yet. Has Dr. Wong had a case of primary upper expansion? Can you read these? I've just lost my voice recently.
Has Dr. Wong ever had a case of primary upper expansion where the second primary molars expand to an ideal width, but the unerupted permanent molars are still almost a full centimeters too narrow? It also appears that the anterior posterior dimension of the arch has decreased. I wonder if this is because the alveolar arch distorted without opening the suture. So it doesn't actually say whether this is upper or lower. So I'll answer this in 2 halves. The upper arch development is sutural if the expansion is done at the semi-rapid rate. Semi-rapid rate being approximately a little under 1 millimeter every 8 days. If this is managed well with a removable acrylic palatally adhesive appliance, like the appliances that I've created, the Wong stage 1. If we have palatal pressure across the entire palate with acrylic, if the retention is very strong, if the expansion is done at that 0.8, 0.9 millimeters for 8 days, then sutural development will not leave the 6-year-old molars behind, because the 6-year-old molars are housed within the palate or dental alveolar. But if the rate of expansion does not follow that rate, if it's too fast, if it's too slow, if there is no palatal acrylic, if the retention is poor, then what will happen is the primary molars will tip. There will be no palatal sutural development. And then effectively, you've just moved the primary molars out laterally, but left the palate unchanged in its form. And in those cases, I would expect the 6-year-old molars to erupt into the old positions, because nothing has changed other than moving through tipping the primary molars. So that's the upper arch. In the lower arch, there is no sutural expansion. So if the lower expander does not have an acrylic free end saddle extension to include the dental alveolar bone that houses the unerupted 6-year-old molars, then those 6-year-old molars will be left behind, as expansion only occurs where the acrylic is in contact. And typically, the 6-year-old molars will be left behind, because most designs that are done by clinicians not under my supervision will not include that free end saddle extension, and all the pressure change induced by the expander will be in the anterior region and will exclude the unerupted 6-year-old molars, and you will typically have them erupt back into the old position, even though the molars are expanded out. Next question.
Yeah, if you can read out 95. So it's a follow-on to previous
In
question.
these cases, do I wait and expand again after the first permanent molars are up? Do I work with an osteopathic doctor or craniosacral therapist to release the locked sutures in the facial bones? I haven't faced these situations for well over 10 years, because early on in my journey, I learned this failing can happen if I don't follow these protocols that I developed. If I expand at the right rate, if I include the yet to erupt molars in the lower, then I don't face these circumstances. When I did encounter these initial problems many years ago, I had to create additional appliances to specifically move the 6-year-old molars. So I would modify my appliances to include individual springs to move the 6-year-old molars into the correct positions. If my anterior to the 6-year-old molar arch dimension was already correct, if I just re-expanded, then I would be overexpanding the anterior and the middle segments unnecessarily. So no, you can't just expand and keep expanding with no thought and no regard to the relationships that are required for proper occlusion. Have I worked with osteopathic doctors? Yes, I have. Parents always say when we have them work with the osteopaths that the osteopaths are very pleased with the combination of the arch development in the lower and the palatal expansion in the upper with their treatment. Generally, though, I tend to work with osteopathic doctors only when the family is already having their children treated by osteopathic doctors. I don't, as a rule, refer my patients to osteopathic doctors during the treatment, because I found when I stick to the protocols that I created that I get the changes that I need very consistently without any real hindrances. The systems that I've developed are quite mature now, with over a decade of outcomes that are consistently favorable. So what I prescribe is more often than not enough to achieve the goals.
All right. So anyone with any questions? Dr. Viet from California, welcome. Thanks for joining us. Dr. Fong from Malaysia, welcome. I know you joined our 2-day program just today, or was it yesterday? Welcome. If you have any questions, feel free to share in the chat area or in the Q&A chat pod area. This is a good question. Simon 88, you want to read this one out while others are thinking of their questions? Wouldn't most removable and even fixed expanders decrease available tongue space?
Absolutely. And anything we put in the mouth reduces the tongue space. We specifically use very bulky appliances in my protocols, and there is absolutely an unfavorable relationship between the bulk of the acrylic and the volume of space that we eat up that the tongue would normally occupy. What rationale do I have for using bulky appliances, even though my ultimate goal is for the child to rest with lips together, teeth together, tongue filling the palate and the floor of the mouth simultaneously? And the answer that I have to that is the children that come to see me have significant malocclusion and very often airway disturbances. These children don't really ever fully close their mouth. So these are children who have their mouth open most of the time, and their tongue is rarely occupying the palate. So when I put my bulky appliances in their mouth, even though it takes up tongue space, their posture doesn't really change because their mouth is open enough naturally, normally, that it makes no difference. After I put the appliances in, we start the process of developing space. And the space that I develop becomes greater than the volume that is needed for their tongue in a very short time. And so even though the appliances take up tongue space, we recreate or we create additional space beyond what they would normally have at that age point. So within a very short time frame, we go from we've eaten up more tongue space than they had originally to we've got more tongue space than they are used to in a very short timeline. And at that point, we can train them to close their mouth. And the combination of closing their mouth with appliances in their mouth puts slightly more pressure on the palate and the dental alveolar surfaces because we're causing a slight crowding of the mouth with the combination of plate and tongue. And that actually is what I suspect creates the amazing changes that I see when I use bulky acrylic appliances. A short answer to that is these kids have had their mouth open for their entire life before they come to see me. Sticking a couple of blocks of plastic in their mouth means that they continue to have their mouth open for another 3 or 4 months. But what's the difference between having your mouth open for 9 years versus 9 years and 3 months? The answer is nothing. But after that initial 3-month period, I can train them to effectively close their mouth. And although it was worse for the first period, it gets significantly better after that first initial development.
All right, those are pre-submitted questions on our website. To those of you who've just joined us, welcome. Dr. Rizvi, I know you had a lot of questions for Simon. Do you want to unmute or do you want to type in your questions, or anyone for that matter? Simon's only available for another 10 or 15 minutes before he heads off back to work. He's having a lunch break right now. So once again, every Wednesday evening, well, sorry, every twice a month, every other Wednesday evening, 10 p.m. Eastern, 9 p.m. Central, or 7 p.m. Pacific. Simon will, spend 40, 45 minutes with us during his lunch break, answer any questions you might have. And obviously, it's more relevant for those who are going through the 2-day program. So one of the things that we've created is not just the live stream, which is a 2-day immersive event, but if those 2 days, the timing is not that great because you're in different parts of the world, you can watch the 2-day recordings from 2 weeks at this time and ask your questions. So you can still get interactive participatory CE credits if that's what you need or want. But yeah, if you have any questions before Simon heads off in about 10 minutes, fire away. Surely you've got a few questions, if some of you have just joined us, Dr. Fong, or some of you are thinking about joining, or some of you are past students. Do you have any questions on your mind? Can you guys hear me okay? Just type hello if you're there. Right. Just see. Otherwise, I will kind of just go through quickly. Okay, Dr. Rizvi, yes, go ahead, please. Do you want to unmute? I can allow you to talk if you want. There you go. You don't have to turn on your videos, but you had a few questions for me, but I'm not the dentist. My brother is, and I just handle all the.
Hello.
Hello, Dr. Rizvi. Welcome.
Okay, hi. Thank you for having me. Thank
Yeah,
you
welcome.
for facilitating this. No, I apologize because I kind of jumped on late, so I don't
Not a
want to
problem.
ask any questions that have already been discussed, and I'm new to this program, but we do myo brace in our office, and then I know some other doctors do like Vivo, so there's like a lot of like, so I understand like the concept, like Dr. Mew's concept and myofunctional. I am familiar with that. I just wanted to kind of, I guess, learn more about your system and how it differs from other systems or brands that are out there.
Yeah, the reality is there's lots of techniques that have been developed over the last 100 years, and many of them work. The focus of each technique varies to the technology available, to the preferences of each clinician. The body responds to the pressure of our appliances. It responds to the pressure of uh, how we interact with our environment. We are all searching for systems that provide consistent, predictable outcomes. And I've only found a handful of systems that consistently provide predictable, favorable outcomes. And one of those systems is fixed braces. One of those systems is Invisalign. Right? They consistently and predictably move teeth into desirable positions. As far as dental alveolar development from AP relationships, from expansion of the arches, I've never really found systems that consistently, predictably provide the same level of reproducibility. And that's one of the reasons why there's only two systems available for moving teeth, which is fixed braces and Invisalign. And there are 1,000 systems available for class 2 correction, class 3 correction, arch development. It's because sometimes things work and sometimes they don't. And we're just playing a very poor numbers game of gambling. I've been very fortunate to have come across the concept of posture being the etiology of malocclusion. And that's basically pressure or lack of pressure from the environment on our body parts. And that pressure or lack of pressure, whether it be from the environment, whether it be from our own actions, creates change, biological change. Because I've researched and understood this concept that posture is the root cause of good or bad malocclusion or occlusion, I've been able to utilize these fundamental understandings to design my appliances and to design my protocols and to make use of retraining children specifically for postural improvement. So posture, when I'm talking about posture, is the still position, the static position that we hold. So the concept is if we rest with our lips together, teeth together, tongue on the roof and floor of the mouth simultaneously for between 4 and 8 hours a day, then our body will adapt the oral facial complex to develop in such a way where everything will be well balanced, everything will be nicely coordinated, we'll have space for all the structures and relationships that are optimal. With this understanding, I've applied my practice to develop appliances, removable appliances that are bulky, with screw expansion rates and wires that develop a very specific amount of pressure over a very specific timeline. And I've combined that with exercises that focus on helping children develop strong oral posture, consistent over a long timeline. That combination together, I found to be so powerful that I'm happy to share my protocols because my results, when we follow them precisely, both clinician and family and patient, we get results that I've never seen in any other systems. A lot of what I created in postural orthodontics was through my learning of John Muir's Bioblock orthotropics. When I applied his techniques specifically to the exact prescription, I was able to achieve skeletal changes as measured radiographically off cephalometric analysis. I found that these enormous changes, favorable, predictable, consistent, over hundreds of patients that I documented, that I've submitted to various universities throughout the world, North America and Europe. And they verified through analysis of these many dozens and dozens and dozens of consecutively treated cases that I've been able to take children who have significant malocclusion, 7 degrees of A and B, and we've been able to bring them into full class 1. So we've been able to take children who have a skeletal malocclusion and we've brought them to an optimal occlusion from a skeletal perspective. This is unheard of. This is not something that we can ever expect to consistently achieve with any system that we have available. Using John Muir's system, I found that I consistently was able to achieve skeletal change. And because of that, it verified to me his theory, Peter Bishang's theory, and Bjork's theory on true mandibular rotation and the postural influence of correct growth or wayward growth. When we follow this protocol, we get changes in AP and vertical dimensions, which go against the grain of understanding of how growth works and what influence we in orthodontics have on growth. The general consensus, despite all our efforts, has been we cannot influence growth. Growth appears to work outside of what we can influence. And as such, we label growth as being predominantly genetic. But when we have worked with techniques that focus on posture, and John Muir is one of those clinicians, Peter Bishang and his teams are one of those clinicians. When we use postural techniques, we can change vertical, and we can change AP dimensions in growing children enough to alter hyperdivergent growth, class 2 growth, class 3 growth, and revert them into a more favorable class 1 relationship. These understandings have allowed me to develop postural orthodontics, which helps focus children with milder malocclusions, children who are prepubertal with milder malocclusions, into developing a much better growth relationship and often much improved dental alignments using removable appliance expanders and the good oral posture exercise process.
All right. There's just you got to go soon, Simon. Dr. Nim has sent a couple of questions. You see them? Want to quickly answer them before you jump off?
I've just got a few questions and then I'm going to head off. So Dr. Viet has said, do I use reverse headgear? Do I believe the whole maxilla is moved forward or only the premaxilla is elongated? When you have, yes, we absolutely use reverse pull headgear all the time in class 3 patients. We always use reverse pull. The part of the jaw that's moved is the part where the appliance is anchored onto. Right? So if you're just pulling on the canines, then only the premaxilla will move forward. But our appliances are anchored on the molars and they are anchored to the palate. And when we pull, the entire complex of the maxilla moves forward. Although it tends, like all reverse pull appliances, they pull down and forward. All right, no appliance ever pulls forward alone. It's always down and forward.
I think Simon's frozen for a second.
And when we improve the bite relationship, we keep the momentum of the downward pull to a minimum. Reverse pull headgear, class 3 patients I'll see from about 3 or 4 years of age until about 10. And whenever we need to, we pull and wear them to do that.
Right.
So yeah, we're always seeing changes in the cephalometric relationships when we measure them. And the reality is, you know, since I think it was 2009 or 11, Mandel ran a randomized control trial that verified that class 3 correction is possible skeletally with reversible headgear. So it's not just me, but everyone on Earth who uses the protocols. 2016, Mandel, early class 3 protraction face mask treatment reduces the need for orthodontic surgery, a multi-centered 2-arm parallel randomized control trial. So we have level 1 evidence basis for the use of reverse pull headgear in class 3 patients. It achieves a skeletal change in outcome if it's done before puberty. And that concludes my session. I'm off to have some lunch. So thank you so much for joining us today.
Perfect. All right, thanks, Simon. I'm just going to stand for 5 minutes. I know some of you are considering joining before the special ends midnight tonight. So thank you, Simon. If you'd like to ask questions about the logistics and so on, I'll just quickly share a couple of minutes Well, firstly, we've got over 450 members already these are paid members, who've joined our 2-day program. And this is where you can ask questions, right? You can ask questions, get support from all the members. But you can tag my brother up until the end of September. So if you're going to be joining for the June event, you got an extra 3 months of support, 4 months of support after the event. So you can ask him more questions. Every 2 weeks, we're going to do these Q&A webinars. So that's going to continue. It's not just leading up to the event. We're going to continue to do these free Q&A sessions every 2 weeks, Wednesday evenings, New York time, 10 p.m. or Eastern. So I understand there's a lot of support. Now, so when is the next event? So we do it once a year. The next virtual, it's last year, it was held at the Hilton in Newark Airport, near Newark Airport, the DoubleTree by Hilton. And we had, Kevin Boyd, Dr. Amanda Wilson, Narinder Singh, Amanda and Kevin and Simon were there physically, and Enrico is the lab that Simon has been using for 20 years, worked very closely with Enrico to perfect these appliances. He was there as well. Professor Narinder Singh, ENT, was joined in virtually via Zoom, but we recorded that event and you get instant access to it, right? But this year, the 2-day event is June 6th and 7th. Starts at 5 p.m. New York time and ends midnight because it's the equivalent of Simon's 7 a.m. So he's starting very early, Saturday morning, which is our Friday, 5 p.m. So it's not too bad for those of you in the West Coast. You don't have to take the whole day off. But these are the 2 days, the 14 hours of CE through the PACE program, AGD. So that's all part of the program. There's multiple choice questions that we'll give you guys if you want the CE. This year, it's just Simon and Kevin, right? You get the recordings from last year, excuse me. But this year, there'll be a 2-hour presentation from Kevin Boyd. He'll be talking about some new research has been focusing on the last recently on how we can optimize the health of our children and their longevity. It's all related to oxidative stress, and that was part of the webinar from last week. That was a big webinar we had with over 560 registrants. So once again, the 2-day event, day 1, day 2, you can see the agenda on our straightteethnaturally.com/program. I was give you that link here in the chat. So agenda for the 2-day event. There's no need to opt in or anything. This is where you can see all the details. The 135 or whatever number that we have published uploaded, as well as they're being researched at the moment in universities. So they're you can take a look at that. And the over 100 peer-reviewed articles are referenced, a lot of them very quickly. And we give you the bibliography of the 2 days. So a lot of, when people say, how are you guys different? Well, we've put together, some of the underlying research my brother's done over the last 2 decades to give the foundations of why he's been getting such amazing results. So you can go through that, the agenda and all that. Excuse me, I just kind of lost my voice. The pricing will be $1,500 probably after mid-May. Currently, it's $1,200 on our website, as you can see. But we had a webinar special that we extended until midnight tonight. Right, so if you don't buy on our website because it's $1,200, but if you want to take advantage of our 297 special, here's the link. It's not just 297; it's 297 upfront. That's the initial payment, and then end of May, we'll charge additional $700. So it's still $200 off the current $1,200 price. And if you leave it till past May 15th, it'll be $1,500. So it's our webinar special that we had from last Monday that we extended until today, because a lot of people couldn't make it. About 40% of the people couldn't watch the webinar with Kevin and Simon, and we've uploaded the full webinar. It's about 70 minutes. Ended up being about 70 minutes. It's all here. just go to the website, check it out. If you haven't, it's a bit late now, but if you want to take advantage of our special, it's just $297 to review everything. You got, until the end of May to get your money back if it's not for you. And if it is, we'll charge the remaining $700. So this is $997 for the 2-day event with the CE and the support. You can stay in the Facebook group and unlimited lifetime access to that. But you've got Q&A support from Simon directly. You can tag him until the end of September. And you get instant access to the recordings from last year as well. All right, yeah. So, and if you're a RDH, if you're a registered dental hygienist or a therapist or speech pathologist, allied health professional, it's just a one-time payment of $275. It's the lowest we've ever sold it for. So if you're listening in and you're a hygienist and love to join, or if you want to get this for your team, it's just $275, and it'll jump to $497, which is kind of the regular pricing we've had. Any questions? Let's see if there's anything else. Oh yeah, so we do include very detailed templates, practice template, over 500 pages of IP. So it's not just 14 hours of video. We've included enough that if you are experienced, and about 7% are orthodontists who join us and they run with it, after the 2-day event, after they review the detailed protocols, how to use the appliances, how to design them, how to order them, the entire GoPEX methodology. We give you the rights to give away our book. It's an illustrated book. We've got this website. You can always easily remember, gopex.us, and you got the full updated ebook version. We just updated this one, corrected a few spelling errors and whatnot. But this is the, 30-page illustrated book you can gift to any parent. They can read through this. There's a 30-day GoPEX challenge, which is included. All the videos, we include the simple step-by-step protocols in this new Google Doc that we've created. Step-by-step. What are all the videos? Watch this. The videos are 1 to 3 minutes. All that's included in as part of our training, as part of the 2-day program. Right. So yeah, so this is just a little video from past attendees. Actually, if you haven't seen this, it's just 2 minutes.
What's happening now is that our kids are they're just eating, in front of the TV, and they're not being supervised while they eat and talk, and they're not being corrected. And that's probably why a lot of the malocclusion is happening, and I never connected the dots on that.
Amanda was actually one of the guest speakers last year, an orthodontist, so she also includes some insurance related tips, how to use the insurance side of things in the US. So that's all included. Last year's 2-day program that we held, this was shot at the New Jersey hotel conference area. She was one of the guest speakers there. It was great. Just accidentally went backwards.
What's happening now is that our kids are they're just eating, in front of the TV, and they're not being supervised while they eat and talk, and they're not being corrected. And that's probably why a lot of the malocclusion is happening, and I never connected the dots on this.
Everything's about airway today, but not many people are doing anything about the posture and the breathing and getting people to change their behavior. As GoPEX teaches, they just say, I'm doing airway stuff.
It's the best thing out there for my child, for the patients in my practice. Life-changing. They can sleep better, breathe better. They're gonna have proper posture. And in this day and age, every 2 to 3-year-old I see has an iPad with your mouth wide open.
It was excellent. I wasn't sure what to expect, but it was surpassed way more than I ever thought. It would be. It wasn't just a simple orthodontic type of thing. It really give you a lot more than what you hear out there.
If we wait too long till the child is done growing, that we're not going to get as good of an outcome, and then we often have to extract teeth or do jaw surgeries or make a compromised outcome in order to give them a result that's straight teeth.
I've taken multiple courses throughout the years. I'm mainly for my own kids, trying to, get them better in many ways. And I found that Simon provided me with all the information that I needed and the treatment that my kids needed. I think not only did the course provide nuggets that I can implement right away, on Monday when I go back in terms of, intake surveys, questions, just questions to ask that I had not asked before. But then it also gives a roadmap of actual treatment, that I can do and that I can implement as well. So I thought that was really great about it.
He's passionate about what he's teaching.
It's life-changing and, and career-changing. I mean, I think that most pediatrics dentists go into pediatrics to make a positive effect on children's lives. And this just allows you to do it in a way that, you maybe only hoped would be something that you could do. So, and yes, please continue this. Please spread the word. It's really great. Yeah.
So some highlights, really heartwarming, testimonials from last year's event, which we recorded, and you get instant access to that, as mentioned. So yeah, the website is, straightteethnaturally.com/297 until you've got an hour left. So basically tonight, and then my team will just remove the special for those who are RDHs. Allied professionals is $275, one-time payment. Obviously a much better price for them. And what else? That's about it, really. Oh, there are some of you from around the world. And if you are from outside of the US, we do have discounts. So just email us at info@straightteethnaturally. I'll just type that in somewhere, and can inquire. Right? It obviously depends on which country. We'll try to make it kind of comparable based on the currency differentials and so on. If you're a past attendee, the refresher rate is just $297. If you just want the recording, it'll be even cheaper than that. If you don't want to attend live. Yeah. So any final questions? There's a few of you still on, the 6 of you. So if you have any quick questions logistically. Now, the recordings you have until end of September. So not only do you get instant access to last year's 2-day intro recordings as soon as you join, the event in June, if you miss a little bit of it, and within a week, we'll edit and so on and so forth. We'll upload it into the same area, and you have access for 4 months essentially, right? End of September. And you can download the audio, you can download the slides, so you can keep a record of it effectively. But if you want to watch the videos, you've got plenty. It's 14 hours, right? You've got solid 4 months or so to go through it. And if you've still got questions for Simon, you can tag him until the end of September inside the private Facebook group, and others can chip in, or you can join every 2 weeks these Q&A sessions. Right? So plenty of support if you need it. And of course, there's advanced training if you're interested, and we'll discuss that obviously at the end of the June session. If you're interested, but this is from anything from advanced training where you can see him at his clinic for a whole day, more detailed appliance training, to more, we had max fac surgeons come in and had a chat, and dozens of hours of training. And we also have hundreds of cases that have been completed. There are, half a dozen mentoring students at any given time that he mentors every 2 weeks for 4 to 6 hours on the weekends. And we've documented hundreds of those cases from beginning to end. The progress photos, x-ray, ceph analysis, we've categorized them into 10 folders. You can go, hey, I've got a class 2 div 1, I've got a class 3 low angle case. Go into the folder, see dozens of completed cases from 0 to 18 months. On average, these mild malocclusion cases that we recommend the beginners who typically join our mentoring program, they're relatively new. And half of the mentoring students are doing it because they've got kids themselves that they want to treat, and no local orthodontist wants to do it, so they'll take it into their own hands and treat their own children with the supervision of my brother every 2 weeks, all done virtually. So sometimes people ask, what is the difference? Well, there's a lot of programs out there, but not all of them necessarily provide mentoring and supervision at this level, where you've got, you know, access to someone like Simon, who's one of the top orthotropists and the creator. I mean, what is the difference between orthotropics? You see a lot of Simon's cases on the website that took 5 years to complete. A lot of them were very severe malocclusions, right? And we focus on, you know, teaching those just that are mild to moderate malocclusion cases that take 18 months to finish, 12 to 18 months on average, because he doesn't want to teach stuff that could take 3 to 5 years of supervision. Start with the easy cases, he would say, right? Just like with anything. He's been doing this for 20 years, don't forget. So we just want to be 100% clear. You know, we're not here to teach orthotropics, which is the first 18 months is still postural orthodontics, because I had to wrap my head around it. Well, how we, you know, are you not teaching stuff that you do? So the stuff that I do, some of it's really advanced stuff. Could take 3, 4, 5 years of treatment. So, but the first 18 months, and if they're mild to moderate malocclusions, is basically the same appliances, the same techniques, you know, so on and so forth. It's just that, you know, if there's really severe malocclusions, correct me if I'm wrong, Simon, later, but he's using slightly different appliances, which are even more penalty driven, that they, you know, they can't open their mouths without, you know, really make sure that their mouth is closed, because the whole posture is key, as you mentioned. A lot of research has shown that functional appliances can do so much only, you know, can move the teeth around, but if you want skeletal changes and so on, and, you know, for correcting some of the more severe cases, then, you know, you got to really correct the posture over a number of years. All right, so any final questions? But that's about it before I completely lose my voice. Thank you for joining. Hope you guys join our 2-day program in June, or as I said, if you can't you know, attend the entire 2-day event, don't worry, you've got the recordings from last year. It's really essentially the same core content, right? It's just that we had slightly different guest speakers, but you get both recordings anyway, right? So, alrighty, thank you guys. Hope to see you in June, and we'll be here again in about 2 weeks. If you've got further questions, I know some of you have already joined, so welcome. And go through the recordings, and you can use these Q&A sessions to get some of your questions answered directly. All right, guys. Thanks so much. Take care. Have a good evening.